Welcome everyone to the EHRA Flash News, your daily scientific update from the final and most memorable day of EHRA 2026 here in beautiful city of Paris. What a congress this has been! 3 days of outstanding science, vibrant debate, and remarkable collegiality from an EP community that continues to push the boundaries of what is possible for our patients. Today was no exception, and we have much to cover. The morning opened with one of the most eagerly anticipated sessions of the entire Congress, the late-breaking clinical science in cardiac implantable devices. And it did not disappoint. The first trial that in this session was the left bundle CRT trial, a non-inferiority randomized trial comparing left bundle branch area pacing and biventricular pacing for cardiac resynchronization. The trial was presented by Oscar Cano Perez. This trial was simultaneously published in the European Heart Journal. This trial was a multi-center, randomized, investigator-initiated trial that included 176 patients with 1-to-1 randomization to BIV pacing or left bundle branch area pacing. The trial showed that left bundle branch area pacing did not demonstrate non-inferiority in the intention to treat analysis, while on-treatment analysis suggested comparable efficacy. Both strategies yielded higher response rates and similar clinical outcomes. Further exploratory analysis suggested better response with left bundle branch area pacing in comparison to left ventricular septal pacing. Another trial that was presented was the LICAR trial, presented by Jean-Benoît Levola-Duvaroux. This trial compared left bundle branch area pacing and biventricular pacing for cardiac resynchronization therapy. It was a superiority trial with a primary endpoint in time to first occurrence of death, hospitalizations for heart failure, any device-related complications requiring a surgical reintervention, and failure to deliver the assigned resynchronization. It included 172 patients and showed that patients who were assigned to left bundle branch area pacing had a lower incidence of the primary composite outcome of death, heart failure hospitalizations, and device-related complications than those assigned to BIV pacing over a 1-year follow-up. Left bundle branch area pacing was associated with significantly shorter procedure and fluoroscopic times and greater reduction of the paced QRS. Left bundle branch area pacing provided similar functional improvements and reverse remodeling as BIV pacing. Left bundle branch area pacing appears to provide an effective and practical strategy for cardiac resynchronization. We then turned our attention to the second late-breaking session of the day, the late-breaking science in ablation and drug therapy, which brought its own share of headline-worthy results. One of the trials revealed during this session was the FLECA-ED trial. It was a randomized clinical trial presented by Panagiotis Tsiofis. This trial explored efficacy and safety of flecainide versus amiodarone for the cardioversion of paroxysmal atrial fibrillation in patients with coronary artery disease without residual ischemia. It included 87 patients randomized to either amiodarone or flecainide. The FLECA-ED trial showed that flecainide was superior to amiodarone in achieving cardioversion in 2 hours, 4 hours, and 6 hours, which was the primary endpoint leading to a discharge from the emergency department with the Holter monitoring device. Furthermore, the FLECA-ED trial showed that among cardioverted patients, flecainide achieved faster cardioversion beyond increased cardioversion rates. Intravenous flecainide demonstrated similar safety profile compared with amiodarone without any proarrhythmic effects. These findings challenge the long-standing CAST-based contraindications to the use of flecainide in all coronary artery disease patients. Beyond the late-breaking trials, today also featured one of the most forward-looking and exciting sessions of the Congress, the competition for the best innovation in AI and digital medicine in clinical EP. 4 carefully selected innovations competed before an enthusiastic audience, showcasing the remarkable pace at which AI and digital tools are transforming the way we diagnose, monitor, and treat arrhythmias. The session was expertly hosted by David Dunker and Emma Svenberg and served as a vivid reminder that the future of EP is not only about novel devices and drugs, it is equally about the intelligent use of data. As the afternoon drew to a close, the Congress concluded in the most fitting way possible, with a memorable and heartfelt closing ceremony. The chair and co-chair of the Scientific Congress Program Committee, Stylianos Tsais and Atasia de Groot, delivered inspiring closing remarks reflecting on the extraordinary breadth and quality of the science that EHRA 2026 brought to Paris. The ceremony was also the occasion for the presentation of the Congress Awards, recognizing excellence across a wide range of categories, including the best clinical case in implantable cardiac devices, the best clinical case in supraventricular arrhythmia, the best innovation in AI and digital medicine in clinical EP, the eCardiology Award, the Young Investigator Clinical Award, and the Young Investigator Basic and Translational Award. To every awardee, your work represents the very best of our community, and your contributions inspire all of us to reach higher. Congratulations. And on that note, we now leave Paris with a final and remarkable statistic. The EHRA 2026 welcomed more than 7,100 delegates from across the globe, making this one of the largest and most internationally diverse gatherings in the history of our Congress. It has been an honor to share this week with you, and we are very much look forward to welcoming you again in the next EHRA Congress. Until then, keep pushing the boundaries of EP and see you next year for EHRA 2027 in Helsinki from April 11th until April 13th. Thank you.